can do steric even hindrance to block those autoantibodies binding to the pole. So.
And then second question now, I've remembered it. In the clinical trial, how are you going to overcome the fact that the patients are actively producing antibodies, have B cells and T cells that are doing their nastiest at that moment in time?
Right. So we believe that this is a very unique mechanism. So we can probably go with steroids, go with immunosuppressant. Of course, obviously not plasma exchange, right? That's obvious. But other than that, we probably can go with them.
Okay, so your clinical trial design would be like standard of care with steroids and IVIG maybe?
That's now we're thinking.
Versus
now
add on this?
That's now we're planning, yes.
Any other questions? Yeah.
Very interesting talk, by the way. So I have two questions. Have you measured the concentration of your chimeric or recombinant antibody in the brain and compare that to the autoimmune antibody causing the disease?
Right. So our antibody in that IP dose experiment, CSF concentration was actually 1 to 2 microgram per ml in a CSF. And that antibody from patient in the CSF was 10 to 20, as we just expected from our preliminary experiments. Yeah. Is that you asking?
I was actually asking the concentration in the tissue. The question is if
right, not CSF, but tissue.
Yes.
Brain parenchyma.
Yeah, because
ISF.
if there is an antibody, it's always the question how the antibody will reach or
I know.
the cell.
Right. So that's a very important question. We didn't measure it. We just measure that surrogate CSF concentration only in this case. So we need to know, and we look into, yes, that's a really important thing.
Hi, thank you very much. Leonie Müller-Jensen from Berlin. I was wondering, did you also look into what happens when you stop antibody treatment? Do you encounter some kind of rebound phenomena or anything?
So we didn't have that kind of luxury, so we didn't do it yet. So yes, that's a really important point.
One last question, yep.
So if I understand correctly, the idea is that your ART is passing the blood-brain barrier, right?
That's correct, yes.
And my question is, how do you think this is happening? Is it the neonatal FC receptor that is transporting? And if this is the case,
yes.
Do we know if the LALA mutation alters the affinity with the FcRn? Neonatal FC receptor that is transporting, and if this is the case,
yes.
do we know if the LALA mutation alters the affinity with the FcRn?
I'm thinking every day, but still in this field, no clear answer yet. But clearly 0.1 to 0.2% from bloodstream to the, say, CSF in this case is really happening. And that was really confirmed in the marmoset, confirmed cynomolgus monkey, and confirmed in rats too. So.
And do you know if the LALA mutation alters this affinity or the FC part with the...
No, doesn't affect FC. I don't think so. Yeah.
Okay, thank you.
Great, thank you very much. That's obviously been a very thought-provoking talk, so round of applause
Thank
for
you.
excellent
Thank you so
talk.
much.
Thank you.
All right, let's move on to the next speaker, whose topic is povetacicept, or potent dual BAFF/APRIL antagonist to suppress disease in a mouse model of autoimmune encephalitis. Please.
Great. Well, thank you so much to the conference organizers for this opportunity to present our work on povetacicept, which, as he said, is a potent dual BAFF and APRIL antagonist therapeutic candidate. These are my disclosures. So BAFF and APRIL are TNF superfamily members that are expressed primarily by myeloid cells and are elevated in various antibody-related diseases, including autoimmune encephalitis. APRIL binds TACI and BCMA, while BAFF binds TACI, BCMA, and BAFF-R. As shown at right, these BAFF and APRIL receptors are expressed at different and often overlapping stages of B-cell development. BAFF-R is expressed early in development, but not on antibody-secreting cells, whereas TACI is, on the other hand, is upregulated on more mature B cells, including germinal center B cells and plasma cells. and BCMA is expressed on memory and antibody-secreting cells. These expression patterns differ from anti-CD20, which is the target of antibody drugs, as you all know, such as rituximab, which is poorly expressed on antibody-secreting cells, such as plasma cells. Together, BAFF and APRIL support B-cell development and differentiation and survival. Autoimmune encephalitis, or as known in my talk, it's going to be AIE, and as you all know, is characterized by antineuronal autoimmune responses, sometimes as a paraneoplastic manifestation of an underlying cancer. The most common is anti-NMDAR encephalitis, but several autoantibody associations have been described, including both antineuronal cell surface and neuronal synaptic proteins, as well as intracellular neuronal proteins. Treatment includes prompt immunomodulation, such as high-dose corticosteroids, IVIG, or therapeutic plasma exchange, in addition to treatment of the tumor in paraneoplastic cases. However, there is no clear best practice, and there are no approved therapies. B-cell depletion with anti-CD20 targeting drugs, such as rituximab, have been encouraging and suggest that B-cells play a key role in disease pathogenesis, but responses can be incomplete. Antagonism of BAFF and APRIL may be advantageous over CD20 depletion by better targeting antibody-secreting cells. Furthermore, BAFF and APRIL have been reported to be elevated in the CSF of AIE patients and associated with worse outcomes, further supporting a BAFF-APRIL targeted approach in the treatment of AIE. So as noted, BAFF and APRIL play key roles in the promotion of autoantibody-producing B cells, as well as pathogenic T cells and innate immune cells. Upon migration to the draining lymph nodes and crossing the blood-brain barrier, anti-NMDAR and non-anti-NMDAR autoantibodies can damage neurons and attack or block receptors, amongst other sequelae, resulting in dysfunctional signaling and neuronal hypoactivity. Povetacicept is a dual BAFF-APRIL receptor Fc fusion of TACI. It suppresses the formation of autoimmune cells and autoantibodies, and we hypothesize that povetacicept could play a beneficial role in reducing antineuronal antibodies and the ensuing encephalitis. Furthermore, by blocking these cytokines critical to the development of autoreactive B cells, povetacicept may exert a significant disease-modifying effect. To evaluate whether povetacicept may be efficacious in AIE, we studied a mouse model of anti-NMDAR encephalitis induced via repeated immunizations with an encephalogenic GLUN1 peptide. Treatment with povetacicept, a matched Fc control protein, the FcRn blocker efgartigimod, or a commercial depleting anti-mouse CD20 as a rituximab surrogate, was initiated at week 4 of the model when serum levels of anti-GLUN1 IgG antibodies were high. And then just prior to the end of the study, neurobehavioral tests were conducted to assess cognitive function. We chose 2 tests that had been shown to be affected in a version of this model and that assess cognitive deficits associated with AIE. Healthy mice prefer to spend more time with another mouse and will investigate a new mouse more so than a familiar one. This normal social novelty is evaluated in a 3-chamber test on the left. AIE mice treated with povetacicept, shown in green, displayed social novelty behaviors in response to a stranger mouse at levels observed in healthy, naive mice, and were significantly improved compared to Fc control, shown in black, efgartigimod, shown in purple, in response to a stranger mouse at levels observed in healthy, naive mice, and were significantly improved compared to Fc control, shown in black, efgartigimod, shown in purple, and anti-CD20 treated mice, shown in orange. In the novel object recognition test shown on the right, povetacicept treatment also demonstrates significant protection from learning and recognition memory deficits observed in this model compared to Fc control and anti-CD20 treated mice. At the end of the 10-week study, serum was collected and evaluated for levels of anti-gluin-1, an important autoantibody in this model, as well as in patients with AIE, especially NMDAR, or obviously anti-NMDAR encephalitis. Povetacicept treatment resulted in significantly lower anti-gluin-1 IgG and IgM autoantibodies, as well as significantly lower anti-gluin-1 IgA antibodies compared to treatment with FC control, efgartigimod, and anti-CD20. Total IgG, IgM, and IgA were also measured in terminal serum, and again, treatment with povetacicept significantly reduced each of these compared to all of the other treatment groups. As shown in the far right, although efgartigimod was able to reduce total IgGs in serum, it was not able to reduce the possibly higher affinity anti-gluin-1 IgG antibodies, unlike povetacicept, which was able to significantly reduce both total IgG and the pathogenic anti-gluin-1 antibodies. Consistent with the significant reductions in the serum autoantibodies, flow cytometry showed that frequencies of splenic immune cell subsets that play key roles in autoantibody development were also reduced with povetacicept treatment, including significantly lower frequencies of antibody-producing plasma cells shown on the far right panel. This was compared to all other treatment groups, including the anti-CD20. This model is characterized by deposition of IgG in the brain, shown in the upper set of figures, as well as neuronal damage, as evidenced by findings such as karyorrhexis, karyolysis, and pycnosis, shown in the lower figures. Povetacicept was again the most effective of the treatments at reducing IgG deposition, as well as neuronal damage. To help further understand povetacicept's efficacy in this and many other preclinical models, we evaluated tissue distribution in black 6 mice following a single IV dose. What you can see here is that povetacicept treatment, or the single IV dose, resulted in a higher brain and lymph node biodistribution. We hypothesize that this can occur because povetacicept has a lower molecular weight, higher target affinity, and a lower isoelectric point than its wild-type counterpart. So in summary, I'd like to reiterate that povetacicept was highly effective at reducing disease in this anti-NMDAR model of autoimmune encephalitis, and more so than FcRn blockade and anti-CD20 mediated B-cell depletion. Taken together, these studies suggest that dual inhibition of BAFF and APRIL with potent therapeutics such as povetacicept may confer significantly improved clinical outcomes in those with autoimmune encephalitis. Thank you. And I'll be happy to take any questions.
Yeah. Thank you for the nice presentations. Any questions from audience? Okay, I have questions.
Yeah?
So your povetacicept was used during the active immunization period. So possibly suppressing the antibody inductions and affinity maturation in peripheral side.
Question, and I am not that familiar with those kind of sequelae. I can imagine, though, that we do have some proof in some other disease models and some other clinical outcomes where that could be beneficial in those situations, but we don't have any data to support that yet.
All right.
Thank you.
Yes, thank you. A great talk. I have a question about the presence of antibodies in your model within the CSF. Did you find antibodies? And if yes, did the treatment decrease the titers, for example, of antibodies within the CSF?
Yeah, that is a great question. We did not measure the antibodies in the CSF. If I were to do this again, I would definitely do that, but we did not do that. That is a great question.
So did I understand that you used a peptide to induce the encephalitis?
Yes.
So are you able to use a larger protein in order, because, you know, in the EAE system,
Yep.
when people use say MOG 35 to 55, B cells were not necessary.
Yep.
And so if there's any similarity to that, rituximab wouldn't work in this system, right? You could get plenty of EAE in B cell deficient mice when you immunize 35 to 55. But if you use the whole extracellular domain of MOG, then all of a sudden there's resistance, because that's what the antibody is doing.
Yep.
It's helping enhance antigen presentation by bringing in. But if you have, you know, so that the big question is, when you measure antibodies to peptides in, say, MOG EAE, those are irrelevant antibodies. They don't recognize any epitope that's relevant to the disease process. And I want to know whether you've actually done the similar thing, looking to see whether antibodies to those peptides actually can bind native receptor.
Yeah, that is a great question, and I have done a lot of those types of studies with the MOG, peptide versus whole protein, so I get your point, and it's a very good point. We have not looked at that, though, and so that is something that we could definitely explore, and I appreciate that input very much. Thank you.
All right, thank you very much.
Yeah, thank you.
So we'd now like to welcome Dr. Julien Hébert. Dr. Hébert is a clinician investigator, neurologist and epileptologist based at Toronto Western Hospital and assistant professor at the University of Toronto Department of Medicine. He approaches research questions from a clinical epidemiology perspective with research interests that include autoimmune encephalitis and neurogenetics. And his presentation is entitled Acute Symptomatic Seizures Secondary to Autoimmune Encephalitis.
Thank you for the kind introduction. So yeah, today I'll be talking about acute symptomatic seizures in autoimmune encephalitis. These are my disclosures. Seizures are common in autoimmune encephalitis. However, not all patients who seize will go on to develop epilepsy. Patients with intracellular antibodies, patients with difficult to treat seizures from the onset, and patients with delayed to immunotherapy greater than 3 months are more likely to develop a chronic predisposition to seizures. Although immunotherapy remains the backbone of treatment for autoimmune encephalitis and autoimmune encephalitis-associated epilepsy, we continue to rely heavily on anti-seizure medication for symptomatic management, especially in the acute phase of the encephalitis. Prior study found that patients with LGI1 encephalitis who achieve seizure freedom without receiving immunotherapy, typically due to delays in making the diagnosis, were more likely to have received sodium channel blocking agents. And in a subsequent study, patients with LGI1 encephalitis who had received carbamazepine were more likely to be seizure-free regardless of immunotherapy status. So this led us to build a study to determine what were the factors that are associated with the development of acute seizures in autoimmune encephalitis, and whether there are anti-seizure medications that are associated with shorter times to electroclinical seizure freedom after adjusting for immunotherapy. Patients who were hospitalized and underwent an EEG and were diagnosed with probable or definite autoimmune encephalitis were retrospectively identified at one of the 2 participating centers over an 11-year period. The primary outcome for this study was the development of acute symptomatic seizures, and the secondary outcome was the time to electroclinical seizure freedom. Our exposure were the different anti-seizure medication received, as well as the times to immunotherapy and to the first anti-seizure agent, as well as the order in which the different anti-seizure medications were received. For the primary outcome, we use univariate analysis and a multivariate logistic regression to assess for factors associated with the development of acute seizures. And for our secondary outcome, we use a Cox hazard ratio with a mixed effect to assess whether there was anti-seizure medication types that were associated with shorter times to electroclinical seizure freedom. We identified 102 patients with median time from symptom onset to admission of 32 days, median length of stay of 23 days, and in total 930 days of EEG were obtained on those patients for a median of 5 days per patient. Nearly 3/4 of patients with autoimmune encephalitis in our cohort had acute symptomatic seizures, typically a combination of electrographic and clinical seizures. Non-epileptic events were relatively common, typically co-occurring with epileptic graphic and clinical seizures. Non-epileptic events were relatively common, typically co-occurring with epileptic events. On EEG, focal slowing, interictal discharges, and periodic discharges, especially if frontally located, were associated with a higher chance of electrographic seizure. Patients with cell surface antibody were more likely to develop acute symptomatic seizures, either clinically or electrographically, and this correlation was maintained even after adjusting for sex, age at onset, and MRI and EEG findings. In the overall cohort, no single anti-seizure medication was associated with decreased time